Welcome to Analgesia, Sedation, and the Incorporation of Ketamine. My name is Rick Nye, paramedic and instructor at Southwest Tennessee Community College, and in conjunction with Dr. Joe Holley, medical director for the state of Tennessee EMS, we've put together this presentation to serve as an introduction to the forthcoming generalized pain management protocol, as well as the incorporation of ketamine into the Tennessee state protocols. Our objectives today are to introduce the concept of generalized pain management when it falls outside the scope of a classically defined protocol, its importance, and some of the safety considerations that you need to have when administering analgesia to your patients. We're also going to introduce ketamine. We'll start by discussing its pharmacology and then its application, incorporating the pearls, pitfalls, myths, and misconceptions to optimize your ability to deliver it safely and effectively to your patients. We're going to start by discussing the importance of general analgesia and sedation. Our goal in EMS is to limit the suffering and damage caused to our patients by their injuries to the greatest extent possible before we turn over care to the hospital. Poor pain control can limit our exam due to the presence of a distracting injury, and it can also cause a skew in their vital signs, where a patient who is otherwise stable may appear shocky due to tachycardia and tachypnea brought on by a severe injury that is not causing hemodynamic compromise. But pain can also cause direct harm to our patients. During an MI, even if it doesn't meet the STEMI criteria and therefore falls outside your ability to give analgesia under the old protocols, or during a CHF exacerbation, that chest pain and that anxiety can increase myocardial oxygen demand. It also causes increased systemic vascular resistance, which can be severely detrimental to a patient with aortic injury. Untreated pain also results in an increase in intracranial pressure, which is detrimental to patients with intracranial hemorrhage. Pain, whether the patient is intubated or not, results in poor respiratory compliance with artificial ventilation, whether that's with a bag valve mask, a non-invasive machine, or through an ET tube attached to a ventilator. And lastly, agitation and psychosis, whether it's psychiatric, secondary to pain, or an acute intoxication, pose a great safety risk to both patient and provider. This risk can be mitigated by the appropriate administration of analgesia or sedation as appropriate. Before we go any further with the presentation, it's important for us to take a brief look at the concept of sympatholysis. Having a uniform definition of this will enable you to get the most out of the rest of this presentation. As the name would suggest, sympatholysis is a blunting of the sympathetic nervous system. As you know, in a shock patient, the sympathetic nervous system is responsible for maintaining blood pressure and cardiac output. But as discussed on the previous slide, in the setting of MI or aortic injuries, we don't always want the body's natural response. So by administering analgesia and or sedation, we can do some good by blunting that response, decreasing the myocardial oxygen demand, chief among them. We can also achieve behavioral compliance of our patients, particularly the ones in excited delirium, where their sympathetic tone represents an imminent life threat. It can also be good for gaining compliance over patients in respiratory distress, either allowing them to breathe at a more effective rate and depth or allowing you to artificially ventilate them at a more effective rate and depth using either a BVM or a ventilator. However, too much sympatholysis can be extremely detrimental to our patients. Overdoing it is akin to kicking a leg off of the table. If you take a patient who is compensating for their shock using endogenous catecholamines and you blunt the sympathetic tone, you can cause that patient to decompensate and crash rapidly. With our one definition slide out of the way, let's dig into the applications for a new generalized pain management protocol. This protocol will allow you, the paramedic, to manage your patient's pain at your own discretion, regardless of the pathology-specific protocol that they may or may not fall under. Possible applications for this include aortic injuries, where the current gold standard in management is aggressive pain reduction and heart rate management to reduce the strain on the aorta and prevent an exacerbation of the injury. This protocol will also be helpful for your cardiac patients where they don't necessarily meet ACS criteria for your protocol, but they have a convincing story or presentation where you suspect that providing some reduction in myocardial oxygen demand would be beneficial to your patient. Additional application may include abdominal pain patients. These patients are often undertreated, and failure to appropriately treat them can be both unpleasant for you as a provider, and it certainly is for the patient. Pathologies such as gallstones and pancreatitis are tremendously painful, even in the acute on chronic setting, and warrant treatment whenever possible. In years past, EMS has been reluctant to administer pain medication to patients reporting abdominal pain out of fear of masking the physician's exam at the hospital. There have been several studies done that have thoroughly debunked that claim. If you work in a system where that is still a concern, a thorough history taking on your part and communication of that history and presentation to the receiving staff on your arrival will go a long way in ensuring that the patient gets appropriate care, both from you and from the hospital staff. This protocol may also allow you to utilize an analgesic agent as an adjunct to a sedative during procedural sedation. It's important to note that GABAergic medications, such as all benzodiazepines, propofol, and etomidate, do not provide any pain relief to your patient. Although they may appear completely sedated, it may still be possible for them to feel pain, and thus the utilization of an analgesic adjunct is appropriate for those patients. For non-cardiac procedures, you will now also be able to consider using ketamine, which provides both sedation and analgesia. More on that to come. So how do we select our patients to apply a general pain management protocol? The first and most obvious criteria would be a patient in severe pain who falls outside the purview of an already established protocol. Typically, severe pain is classified as being 7 out of 10 or greater, or may be defined by your agency local or regional guidance. It's important to remember that this scale is remarkably subjective, and it's important for you to use your good judgment in conjunction with the patient's history and your assessment in determining who is in severe pain and warrants use of this protocol. It may also be useful in the case where your exam is limited by a distracting injury or other condition not covered elsewhere in the protocols. One of the most important applications for a general pain and sedation protocol would be a deleterious sympathetic state, where a patient is too combative or in a state of psychosis that puts them, you, or other responders in danger. In identifying these patients, it's important to look for physiologic manifestations such as otherwise unexplainable tachycardia, hypertension, agitation, or restlessness. This protocol will also allow you to use your compassion and good judgment in otherwise stoic patient populations. It's important to consider that elderly patients frequently underreport their pain, even when the injury is obviously uncomfortable or severely painful, and their vital signs are suggestive that they are in more pain than are reporting. This will also allow you to treat patients for pain where there may be a language barrier and you cannot appropriately assess or adequately assess the patient's pain on a numeric scale. Please recognize, however, that consent is still required before administration of any medication. This protocol simply allows you to initiate the conversation with the patient and to offer them relief, even if their complaint or assessment does not fall under current protocols for administration of analgesia. One of the biggest concerns with the implementation of a protocol like this is how, as providers, do we avoid patients abusing this protocol? It's important to keep in mind that in general it is better to treat a patient faking or overstating their pain than it is to withhold medication from a patient who is truly in pain or underreporting their pain. There are some ways that as a provider we can attempt to tease out who may be overreporting their pain by looking for the physiologic manifestations of pain, tachycardia, hypertension, agitation, or restlessness. Though it's important to remember that the absence of any of these does not necessarily mean that the patient is not in pain. The patient taking a beta blocker or an antihypertensive, for instance, will not present with the same tachycardia or hypertension that a patient not on these medications would have. It's also important to recognize that pain is entirely subjective, and even a mild to moderate injury may indeed be the most pain that that person has ever felt in their life. It's not our job to be judge or jury in the court of pain. It's our job to treat the patient we have in front of us. I also find that an effective strategy for dealing with patients who are in pain is to loop them into the decision-making process, make it a conversation, inform them that the goal of pre-hospital pain management is not to take all of the pain away, it is to make it tolerable and make the ride not a miserable experience for them. It's also important for you to inform them of the risks and benefits of pain medication administration. Oftentimes, if you're on the fence about it, discussing the risks with a patient will lead them to refuse the treatment or affirm that they are in severe enough pain that they accept the risk. These are a few clinical pearls that we feel are important for you to know as you use this protocol in treating your patients. The first is the difference between breakthrough pain management and maintenance pain management. In most cases, the dose of medication required to initially achieve control of somebody's pain will be higher than the dose required to recontrol their pain once they start reporting its return as the drug starts to wear off. It is harder to deactivate active pain receptors than it is to inhibit them from becoming activated. This is important to keep in mind if you are on a long transport and a patient begins to report the return of their pain. Note that their second dose will not need to be as high as the first dose if you treat early. More on this on the next slide. Also, dose and relief is not necessarily a linear relationship. Often there is a threshold of dose before which the patient will experience little to no relief, and beyond which the relief will be diminishing returns as the dose increases. Finding this tipping point is important and a key to proper, appropriate, and highly effective pre-hospital pain management. As a provider, you should obtain a thorough history before administering pain medication to your patient. This includes opiate use by the patient at baseline, be it prescribed or recreational. In these patients, they will require both higher initial and maintenance doses of pain medication. Keep in mind, it's not our role to judge a patient. If you decide to manage their pain, you should do so without regard to a personal history of substance abuse. Be aware that their doses may need to be higher for effective relief. And lastly, keep in mind that fentanyl has a very short half-life. Over the course of a short transport, you may not appreciate this, but over longer transports, it may be prudent for you to redose your patient before arrival to the hospital if fentanyl is your analgesic agent of choice. These are the graphical representations of the dosing concepts introduced on the previous slides. The graph on the left graphs the pain of a patient versus the dose of fentanyl administered as measured in micrograms per kilogram. As you can see, between 0 micrograms per kilogram and up to about 0.6, 0.75 micrograms per kilogram of fentanyl, the pain relief is minimal. As you approach 1 microgram per kilogram, however, there is a precipitous drop in the patient's pain. And as you increase the dose past that 1 microgram per kilogram zone, the pain relief diminishes. You can see that the risk of an adverse event, however, is relatively linear across the whole graph with an exponential rise past about 1.5 mic per kilo. This is important to keep in mind as you select the dose for your patient. Providing too small of an initial dose will not yield effective analgesia. However, stacking multiple small doses may land you as a net much higher than your intended dose, resulting in an adverse event such as apnea or loss of consciousness. The graph on the right shows you the patient's pain versus circulating concentration. So you can see, assuming you administer the correct dose and achieve effective relief of their pain will gradually start to return as the drug wears off. If you're able to re-administer a smaller dose when the patient begins to report the return of their pain, you can typically administer a much smaller dose than you had to gain initial control of their pain. If you wait until their pain returns to the baseline they were at prior to the first dose, you'll have to administer a comparable dose the second time around. This is significant because, as noted on the first graph, a higher dose comes with a higher risk of adverse events. While many protocols advise an adult dose of most medications, it's important to remember that analgesia is intended to be administered by weight. And this becomes particularly important with the broad spectrum of patients treated by EMS. Consider a 20-year-old weighing 220 pounds involved in an MVA and a 90-year-old 90-pound female with a hip fracture. The dose of an opiate required to successfully manage their pain will vary greatly, and it could potentially be hazardous or ineffective for one of the patients if you gave them both the same dose. The doses for both morphine, fentanyl, and as we'll see later, ketamine also are fairly easy to remember and easy to work with. The prudent paramedic will weight-base their analgesic dose. It's also important to remember that opiates are effective when given IM. There are often situations where placement of an IV is not possible due to the patient's position or scene logistics. However, you can safely and effectively administer an intramuscular dose of analgesia that will facilitate movement of that patient and prompt treatment of their pain where they are found. You should note that it is reasonable to increase your dose by about 50% to double based on the patient's response as compared to the intravenous dose. Deep intramuscular injection should be used in the anterior lateral thigh. This will promote the most rapid absorption of the medication and the most prompt pain relief when you're using the intramuscular route. It's also important to anticipate nausea. If your patient was nauseated from their pain prior to you administering an opiate, it is prudent for you to administer an antiemetic first. If they were not nauseated prior to your administration, it is reasonable to anticipate nausea in the post-administration period, and the antiemetic should be on hand as well as IV fluids. It's important that you use caution if diphenhydramine or Benadryl is your antiemetic agent of choice, or if the patient reports motion sickness in the ambulance after receiving the opiate. There is potent synergism between opiates and Benadryl with regards to sedation. And as always, anytime you're administering an opiate or sedating agent, you need to consider the risk of loss of airway reflexes and be prepared to manage their airway. Before we get into the heavy-duty medications featured in the rest of this presentation, I think it's worth noting that there are both non-pharmacologic and non-controlled substance methods for managing our patient's pain. It's important to remember that we can do the simple things like ice, positioning, splinting, as well as being calming and reassuring for our patients. If that doesn't work and we're not quite ready to escalate to an opiate yet, there are a few other options. Acetaminophen is becoming more common in EMS practice, although it's predominantly being used as an antipyretic agent. Worth discussing in this presentation, however, is Toradol, or ketorolac, which is a NSAID or nonsteroidal anti-inflammatory drug. It's pretty widespread and gaining popularity, especially in light of the opioid epidemic. It's an excellent choice for any kind of non-operative musculoskeletal pain, chronic back pain, arthritic pain, or my favorite thing to use it for is actually kidney stones. It's able to be used either as a single agent with excellent effect, or will allow you to use a much lower dose of an opiate to achieve excellent control of a patient's pain when they present to you with suspected or known kidney stones based on their history. There's a few things to keep in mind if you choose to use ketorolac. First of all, recent evidence has shown that it requires a much lower dose than we have historically administered to patients. Doses in the 10 to 15 milligram range have shown equal efficacy to the more classic 30 milligram dose. Studies have shown that increasing the dose beyond this only increases the incidence of renal injury without providing any additional benefit to the patient with regards to their pain. There are also a few contraindications with this medication that are very important to keep in mind. It should not be administered to any patient who's on renal dialysis or has a history of renal injury. It's also not recommended for use in patients who have a potentially operative injury. This is due to ketorolac's ability to cause issues with coagulation. Regional, local, or agency level guidance should be provided in consultation with local hospitals and their surgery staff regarding the use of ketorolac for both kidney stones as well as minor orthopedic injuries. For similar reasons, it should be avoided in patients that have a history of GI bleed, hemorrhagic stroke, or any other coagulation disorder. It should be avoided in patients with asthma. This is due to a condition known as NSAID-induced bronchospasm, which is essentially the triggering of an asthma attack secondary to an NSAID medication. Ketorolac should also be avoided in pregnant patients and any patients with a known hypersensitivity or history of angioedema secondary to exposure to an NSAID drug. Now that we've discussed a generalized pain management protocol and we're shifting gears towards introducing ketamine, let's take a second and look at the current options that EMS has available for analgesia. By and large, the two most widely utilized are going to be morphine and fentanyl. Morphine is a naturally derived opiate that has a relatively long half-life. However, it does have a pretty profound histamine-mediated vasodilation, resulting in a poor hemodynamic profile, which can prove problematic for our shocky patients, whether it's from trauma or cardiogenic, where we might want to administer some pain relief. As with any opiate, there is respiratory depression, and it offers a pretty high degree of sedation relative to the analgesia that it provides, and that patients who receive morphine typically become fairly sleepy for prolonged periods of time after receiving it. It is also a sympatholytic, not to the extent that fentanyl is. However, administration of morphine will cause some of that sympatholysis we discussed earlier. Moving on to fentanyl, it's our synthetic opiate option, and that distinction is important because it has a much lower allergic potential relative to morphine. Compared to morphine, fentanyl also has a faster onset of action, but a shorter duration of action. The duration of action of fentanyl can be as little as 30 minutes in some patients. This may be further reduced if the initial dose of fentanyl was inadequate. It is significantly more hemodynamically stable relative to morphine. There is not the histamine release that we see with morphine, therefore there is significantly less vasodilation. And it's not that fentanyl doesn't trigger histamine release, but it is dosed on the order of micrograms. So there are much fewer particles of the fentanyl in circulation, causing significantly lower release of the histamine. This makes it an excellent choice in analgesia for your suspected cardiac or hemodynamically unstable patients, where a slow administration that limits sympatholysis can be an effective modality for managing their pain. Like morphine and any other opiate, it does come with respiratory depression, and it is a potent sympatholytic, particularly when given as a push. Fentanyl is always recommended to be given as a slow push or a short infusion to prevent profound sympatholysis in your patients where they're potentially in shock. So our current options for sedation in Tennessee EMS is predominantly benzodiazepines, whether you're using midazolam, diazepam, lorazepam, which are going to be your Versed, Valium, and Ativan respectively. They're GABAergic medications, and the issues we see with them is they're highly variable patient to patient with regards to both onset, response, and duration. They can come with some respiratory depression, although that is most usually seen when they're used in conjunction with an opiate or alcohol. They are also potent vasodilators, making them inappropriate for shocky patients. Some services have access to some next generation antipsychotics, whether it's haloperidol or Haldol, risperidone, ziprasidone, Georgiadon, or olanzapine. However, these are few and far between, have a variable mechanism that modulates neurotransmitters, and again, we're going to see a pretty variable performance with regards to onset and response, with some patients exhibiting paradoxical reactions to these, and the effect being variable based on the patient's history, whether they take these every day or not. They're also very long acting, which can make the hospital's job in assessing the patient a little more difficult, as they're much more likely to come in completely snowed. And they also come with a risk of the extrapyramidal effects, which can be mitigated with diphenhydramine. However, that is going to enhance the sedation provided by these medications, further lengthening the patient's time in the emergency department and the time until they can be thoroughly assessed. Now, onto the new option, ketamine. We're going to use this slide to give an overview of the multifaceted role ketamine can play in sedation and analgesia, and then we'll dig into the pharmacology of each of these actions over the next few slides. It's classified as a dissociative anesthetic agent, differentiating it from the other sedating agents, such as the benzodiazepines or antipsychotics. It's also a potent amnestic agent. It displays some opiate activity, and it has catecholamine reuptake inhibition. So what is a dissociative anesthetic agent? It's an anesthetic first and foremost, so it inhibits the patient's ability to feel or perceive pain. However, its mechanism, dissociation, makes it quite different from an opiate or a GABAergic agent. It's an NMDA receptor antagonist, which inhibits excitatory signals from the body's pain and sensory receptors, as well as attention and emotion, from reaching the thalamus and corticolimbic system, respectively. You are essentially cutting off the brain's ability to perceive the world around it and have an emotional reaction to it. What's important to note is that the brainstem function remains intact. The patient's respiratory drive, airway reflexes, and vascular tone will remain unchanged by ketamine, except under special circumstances that we will discuss later. An additional benefit of ketamine is that it functions as a potent amnestic agent, making it ideal for both procedural sedation and pain management in traumatic situations. Ketamine also produces opioid activity. It's important to note that it is not a primary opiate. It does not antagonize opiate receptors. It alters their function and produces similar downstream effects to opiate receptor activation. However, it is not binding and activating those receptors in the same way that an opiate does, and it is not reversible by naloxone. This effect is seen predominantly in lower doses of ketamine prior to reaching the dissociative dosing. We'll get to more of this here in just a little bit. There have been multiple head-to-head studies that have compared morphine to ketamine as a primary analgesic agent, and ketamine has been shown to be non-inferior in all of those trials. The final mechanism of action that we need to understand as EMS providers is that ketamine is a catecholamine reuptake inhibitor. This gives it a hemodynamically supportive profile. In vitro, or in a test tube, cardiac myocytes exposed to ketamine showed decreased inotropy. However, in vivo, or within the body, this catecholamine reuptake inhibition enhances the activity of norepinephrine on cardiac myocytes, which results in increased chronotropy and inotropy. This makes ketamine relatively safe to use in shocky patients when appropriately administered, and also explains the transient tachycardia and hypertension seen with its administration in non-physiologically compromised patients. Of note, this catecholamine reuptake inhibition does not equal a contraindication for use in physiologically excited patients. We'll dig into this more just a bit later. And this slide is just a summary of the previous few slides for those of you that like to have a single take-home slide to review. Now, on to patient selection. Who gets ketamine? This slide serves as a summary list, and we'll dig into each of these patient populations over the next few slides. The populations we'll look at are those with excited delirium or extreme combativeness and agitation, intoxicated patients or patients with unknown substances on board, severely injured patients, mild to moderately injured patients, patients in respiratory failure, and those patients that are intubated or receiving non-invasive mechanical ventilation such as BiPAP. Ketamine is a relatively old drug that went out of fashion for many years. It was brought back into the emergency medical world to treat patients with excited delirium syndrome. These patients exhibit psychomotor agitation that can prove fatal, secondary to profound metabolic acidosis and hyperthermia. Ketamine is an excellent choice for these patients because of its mechanism of action. Its dissociative effects prevent excitatory signals from the sensory neurons from reaching the brain and significantly reduce the patient's ability to have an emotional or physical response to those neuronal inputs that are able to make it to the brain. It also inhibits most, if not all, voluntary muscle movements while leaving the diaphragm and respiratory centers intact and preserving airway reflexes. We'll more thoroughly discuss dosing and pharmacokinetics towards the end of this presentation, but its onset is significantly shorter than both benzodiazepines and second-generation antipsychotics. Ketamine is also an excellent choice for sedating the combative patient with alcohol and/or other substances on board. As previously discussed, administering a benzodiazepine to a patient with acute alcohol intoxication prior consumption of antidepressants, barbiturates, or other benzodiazepines represents a severe risk for respiratory depression and/or hypotension. None of these effects are seen with ketamine. Its effects are synergistic with opiate, but the airway reflexes and respiratory drive will remain intact. To date, there are no documented cross-reactivity between ketamine and other classes of medications or intoxicants that makes it a contraindication. In the setting of trauma, there's a role for ketamine in both severely injured patients as well as those with mild to moderate injury. Ketamine can be used to facilitate extrication of severely injured patients, leaving their respiratory drive and airway reflexes intact when access to them for airway management is otherwise limited. The hemodynamically supportive profile of ketamine also makes it safer to use when continuous monitoring is difficult or otherwise impossible due to the patient's location. In the mild to moderately injured patients, ketamine is useful for those that have a poor opiate tolerance or those with which pain control cannot be adequately achieved with opiates. There's also a role for ketamine in patients with a previous history of opiate addiction or those with a family history who are concerned about developing an opiate addiction. Ketamine will yield comparable pain management even at low doses without activating the opiate pathway, triggering a dependence or relapse. Ketamine can also be a powerful tool in managing respiratory failure patients. For your asthmatics or COPD exacerbations that require assisted ventilation, ketamine functions as both a bronchodilator as well as an anxiolytic that will allow them to tolerate assisted ventilation or prolong their expiratory time. In the setting of advanced airway management, ketamine can be used as an RSI induction drug or used for a DSI or delayed sequence intubation or even a facilitated intubation where ketamine alone is used with or without topicalization of the airway using an agent such as lidocaine. The advantage offered by ketamine in these situations is that it preserves the spontaneous respiratory drive, thus allowing you to avoid the negative hemodynamic effects of switching a patient to positive pressure ventilation associated with performing a classic RSI, or from inhibiting the respiratory compensation for a severe metabolic acidosis if present. Finally, it's an excellent choice for intubated or mechanically ventilated patients. It provides a combination of sedation and analgesia and thus can be used as a single agent. It also preserves negative pressure spontaneous ventilation within the patient, allowing for a more favorable hemodynamic profile. Both of these features allow you to avoid having to administer a vasodilating benzodiazepine or opiate medication, thus providing significantly better hemodynamic profile for these sick patients. This is the one-page summary slide for those of you that want to have a quick reference. Now that we've looked at which patients are candidates to receive ketamine, it's important for us to consider who should not receive ketamine and which patients deserve special considerations with its administration. Chief among patients who are not candidates for ketamine are going to be patients suffering acute cardiac events. While the hypertension and tachycardia caused by the catecholamine reuptake inhibition associated with ketamine is transient and in the general population not harmful, in patients suffering acute coronary syndrome, even a transient rise in myocardial oxygen demand can be detrimental. While the sympatholysis offered by ketamine may seem advantageous, that same effect can be achieved quite safely using alternative agents such as fentanyl. There is also a risk of inexpert administration resulting in a partial dissociation, which can severely increase a patient's anxiety, thus further increasing myocardial oxygen demand. For similar reasons, ketamine is contraindicated in suspected or known aortic injury patients. The use of ketamine in patients with known or suspected head bleeds is controversial. Early evidence obtained from patients in the operating room undergoing surgery to remove brain tumors found that administration of ketamine resulted in increased intracranial pressure, and it has therefore been avoided in emergency medical use for patients with head injuries. However, studies in emergency medicine, though limited, have not shown deleterious effects associated with ketamine use in patients with head injuries. It's worth noting that the cerebral perfusion pressure is equal to the MAP minus the ICP, and due to the catecholamine reuptake inhibition properties of ketamine, MAP typically improves during ketamine administration when it is performed appropriately. It follows, therefore, that ketamine may be beneficial for use in analgesia and sedation of patients with head injuries. Furthermore, it's well understood that even a single hypotensive episode in the peri-intubation period of a patient with a known head injury results in a 50% increase in their mortality. Therefore, ketamine warrants consideration for use in RSI in patients with known or suspected head injury. Care should always be taken to avoid partially dissociating these patients, though, which can lead to an increase in agitation, which will result in increased intracranial pressure. Always refer to ongoing state, regional, local, or agency level guidance regarding the use of ketamine in patients with known or suspected head injuries. As with any medication, a known hypersensitivity to the drug is also a contraindication. Of note, a patient with a history of a bad experience or a bad trip on ketamine should not be considered to have an allergy. It is often the result of inexpert or inappropriate dosing and can be safely mitigated by an astute provider. So before we get into actually using ketamine, there's a couple pretty common myths and misconceptions that need to be dispelled. A lot of the pushback that I've received from the community when discussing using ketamine, either with the patient or with their family, is it's got a stigma of being a party drug. And that is true. There is a recreational market for ketamine, but there is a recreational market for any medication that we're going to give to provide pain relief or sedation. So I would make the argument that any of those drugs used inexpertly would constitute a party drug, but as trained medical professionals using it in the appropriate context and the appropriate dosing, it is a medical tool, not a party drug. For whatever reason, the role of ketamine as a veterinary medication has stuck in the minds of many in the general public, and that is true. It did get its start as a veterinary medication, particularly for the sedation of large animals, but a lot of the medications we use are also applicable to the animal population. Morphine is the alternative we would use for pain management in EMS that is widely used in veterinary medicine as well. So we have adjusted our doses to be appropriate for humans, and when used properly and in the hands of trained medical professionals, it's no different than any other medication that can serve both populations. And the third common misconception is that people are guaranteed to have these bad hallucinations or bad trips on ketamine, whether your patient has directly experienced those in the past or just know by reputation that could happen. As we'll discuss over the next few slides, that is often a matter of inexpert dosing, right? We've either given the wrong amount, given it too quickly, too slowly, and people get stuck in a bad place. So with proper training and education, we can avoid those completely. If you do find yourself with a patient experiencing one of these bad trips or hallucinations, there is a way out of that, and we're going to discuss that here shortly. So how do we become experts at ketamine administration? And a large portion of that is going to be dosing, and we're going to cover that right at the end. And the other part is knowing and understanding the pearls and pitfalls around ketamine administration. So we're going to go through those now. One of the major potential pitfalls is the induction of unconsciousness in your patient. It's worth noting that a fully dissociated patient, if that is your goal, can be completely safe. We want to fully dissociate our excited delirium patients. We need to fully dissociate those patients that we're going to be RSIing using ketamine. They will appear to be unconscious and unresponsive, but unlike using any other medication that we're familiar with, their airway reflexes and respiratory drive will remain intact. There is anecdotal evidence of apnea occurring with the administration of ketamine, but that has only been documented in doses greater than 1 milligram per kilogram when it's administered as an IV push. And that happens due to rapid sympatholysis in a shocky patient, somebody who is hanging on by nothing other than their catecholamine, and you rapidly block transduction of those signals and you remove the last leg from their compensation table, like we discussed at the beginning of this presentation. And this phenomenon, should be noted, is not unique to ketamine. You see the same effect in shocky patients with etomidate, even though it is supposed to have a favorable hemodynamic profile. And you certainly see it with medications like midazolam or propofol if they're used as induction or sedating agents in patients with compromised hemodynamic status. When ketamine is administered slowly, either as a slow push or a quick infusion in 50 or 100 cc's of fluid, those effects by and large can be mitigated. However, there is the risk of apnea with any analgesic or sedating medication that we administer our patients. So even though with expert administration it is highly unlikely to encounter this, when you administer any of these substances to sedate or control pain, you need to have a plan for managing this patient's airway in the back of your mind. The next pitfall that is pretty common with the administration of ketamine are providers shying away from it due to previous experience of noting tachycardia or hypertension post-administration, or withholding it from physiologically excited patients not wanting to induce further tachycardia or hypertension. And there's a couple things to consider here that make that not as big of an issue as some providers make it out to be. First, that response is highly transient. So unless your patient is suffering from a myocardial infarction or an aortic injury where even transient rises in blood pressure or heart rate are not acceptable, things will normalize. And in your physiologically excited patients, your excited deliriums, your stimulant overdoses, the sympatholysis that will very quickly follow the tachycardia and hypertension induced by the blockade of norepinephrine reuptake will counteract that transient rise, and you'll see a net reduction in heart rate and blood pressure secondary to the sympatholysis. The most common side effect noted with ketamine administration, as with most analgesic or sedating medications, is nausea and vomiting. In the trials that compared ketamine head-to-head with morphine for efficacy and pain management, while ketamine performed comparably in the primary outcome, it was associated with a higher incidence of nausea and vomiting. Subsequent studies demonstrated there was significant reduction in nausea and vomiting with ketamine administered either intramuscularly as a slow IV push or as a rapid infusion over 5 to 10 minutes. The most practical way to do one of these rapid infusions is to mix your ketamine into a 50 or 100 ml bag and piggyback it into a primary infusion of either saline or lactated ringers. The setup in the picture on this slide demonstrates how to perform that. Note that it is important to leave the bag containing your ketamine mix hanging higher than the bag running your primary line. This will ensure that the small bag preferentially runs through the line first. Other potential side effect of ketamine administration includes hypersalivation. Although this is rare, it is worth considering when using ketamine as an induction agent for RSI or when fully dissociating a physiologically excited patient. Your patient will retain their inherent airway reflexes, so all you should need to do is suction this patient. As such, atropine is not recommended as prophylaxis. However, in the context of RSI, you should be prepared to administer atropine in the event there is excess secretions noted in the airway. This is perhaps the single biggest pitfall we face in pre-hospital medicine and the administration of ketamine. It comes packaged in 3 different concentrations: 10 milligrams per milliliter, 50 milligrams per milliliter, and 100 milligrams per milliliter. Because of this, the volume administered to your patients for an appropriate dose will vary greatly depending on which concentration your service is carrying. In the current climate of frequent drug shortages and cost-saving measures being taken by EMS services across the country, it is possible for your service to change concentration of ketamine on short notice. As with any medication administration, you should be verifying the concentration and the dose before you administer it to your patient. And finally, it is important to not co-administer ketamine and a benzodiazepine in the same IV line at the same time. Although rare, in certain concentrations and ratios, a precipitate can form. Similar to calcium chloride and sodium bicarbonate, it is important to either use different IV sites or ensure thorough flushing of the line in between administrations. This is particularly important, as we will discuss in the coming slides. There is a role for the administration of benzodiazepines with ketamine. So far, we've covered the pharmacology, patient selection, and pearls and pitfalls associated with ketamine administration. Now it's time to learn how to administer it safely and effectively. Unique to ketamine compared to all other sedation or analgesic medications, rather than there being a linear relationship between dose and effect, ketamine dosing occurs on a continuum where there are three distinct effects that we can achieve based on the dose we give. This concept shouldn't be too foreign to providers in the state if you think back to your dopamine education in paramedic school. The three dose ranges on the ketamine continuum are the analgesic dose, the partial or subdissociative dose, and the full dissociative dose. You can see these three ranges represented on the ketamine curve on this slide. It's very important to note that when we discuss these doses, we'll be using ideal body weight. This is not the patient's stated or actual weight. This is a weight based on the patient's height. The formulas for calculating this can be seen just underneath the ketamine continuum on this slide. Accompanying this training will also be ID badge-sized cards that can be used for quick reference, as well as a full-size page that can be adhered inside of your ambulance. These references will provide both the ideal body weight based on height, as well as the approximate appropriate dose for a patient based on that weight in each of the three dose ranges. The analgesic dose ranges from 0.1 to 0.3 milligrams per kilogram of ideal body weight. For reasons we'll discuss when we get to the partial dissociative dosing, it's prudent for you to start on the lower end and titrate to effect. If administering intramuscularly or intranasally, you should start at the higher end of this range. In this analgesic range, we'll be taking advantage of ketamine's opioid-like activity. There should be little to no dissociative activity in this range. This is the range most appropriate for mild to moderate injury. The next range is the partial dissociative dose, which ranges from 0.5 to 1 milligram per kilogram of ideal body weight. In general, we want to avoid this range. This is where a lot of the hallucinations and proverbial bad trips happen. In a partially dissociated state, your patient is only receiving partial or intermittent sensory signals and partial or intermittent emotional responses to those signals. This is a deeply unpleasant state for your patient to be in, and care should be taken to avoid this dose range unless absolutely necessary, and steps taken to get the patient out of this range as quickly as possible. There is some utility in this dose range, however, if you require patient compliance. In recent history, the rescue of the youth Thai soccer team from a flooded cave was accomplished using partial dissociative doses of ketamine. Ketamine was co-administered with a benzodiazepine, and the children were able to tolerate full-face breathing masks to get through the cave while maintaining their grip on a rope and compliance with the special forces to facilitate their own extrication. And the final dose range is the full dissociative dose, which is in excess of 1 milligram per kilogram of ideal body weight up to 5 milligrams per kilogram of ideal body weight. Please note that this 5 milligram per kilogram dose is only utilized with intramuscular injections. The RSI dose is 2 milligrams per kilogram of ideal body weight. Full dissociation is typically reserved for the induction of anesthesia in the setting of RSI, or for controlling an excited delirium patient or a patient posing some other safety risk to themselves or to providers. Ketamine has a relatively short duration of action, with IV administration lasting only 5 to 10 minutes. This is significant in the context of long transport, and particularly when it is utilized as an induction agent for RSI. If rocuronium is utilized as the paralytic, the ketamine will wear off long before the paralytic will, and the patient will require resedation or administration of analgesia before they're able to move on their own or let you know that they're in any manner of distress. The duration is approximately doubled when it is administered IM. It is worth noting that while the analgesic effects will wear off relatively quickly, a fully dissociated patient may remain dissociated for significantly longer, particularly when higher doses are used. I'd like to take this opportunity to go over once again the risk of inexpert administration. In my experience, this is by far the biggest reason providers avoid administering ketamine. All of these reactions occur in the subdissociative zone. That can happen as a patient is passing through that zone on their way to full dissociation, or as they're coming out of full dissociation and the drug is leaving their system. And while this state is transient and not inherently harmful, it places the patient and the provider at risk due to unpredictable behavioral reactions. If you find yourself dealing with a patient stuck in this zone, there are two approaches. You can either re-administer ketamine and get them fully dissociated, or administer a benzodiazepine. The dose of benzodiazepine is typically smaller than the standard adult dose. However, you may need to go all the way up to the 0.05 milligram per kilogram if you're finding smaller doses ineffective. Anecdotally, 1 to 2 milligrams given as a slow IV push is sufficient to get the patient relaxed and through the subdissociative zone safely. And my final point on becoming an expert in ketamine administration is recognizing the patients will lock in to whatever they were thinking, feeling, or hearing right as the drug takes effect. So as you administer, you need to talk to your patient, reassure them, try to provide as relaxing and calming an environment as you can. Even on the scene of an extrication or transport under lights and sirens, it's possible for you to speak calmly and relaxingly to your patient, asking them to envision their happy place, or talking to them about somebody that they love or want to see when they get to the hospital can be of great benefit, as it will cause them to lock in on that thought while they're dissociated or partially dissociated. This is the ketamine dosing guide that will be made available to you and your agencies with this training. I'd like to thank you all for your time, and a big thanks to Dr. Holley for letting me be a part of making Tennessee a better, stronger EMS system, providing better care to our patients. Thank you.